So we're going to look at MecGLA now. As you know, MecGLA is for the treatment of diabetic neuropathy. So when the blood supply to the nerves or the nerve cells comes down, the nerves get less oxygen, and so therefore the nerves are not able to breathe. This is called neural hypoxia. Hypoxia means there is no oxygen, and it also suffers from nerve pain and nerve death, and this is called neuropathy. So diabetic neuropathy causes pain and the sensation of pins and needles in the hands and the feet. So this is what a nerve cell looks like. So these are called dendrites, and this long filament is called axon, and the protective covering on the axon is called myelin sheath, and this is the cell body. So basically this one nerve cell is attached to another nerve cell here. On this side there is another nerve cell. So the axon of one nerve cell is attached to the dendrites of the next cell, and over here the dendrites are attached to the axon on this side. So like this the signal can go up and down. So as you can see here, the nerve cell also requires oxygen, a blood supply and oxygen to do their work. So there are microcapillaries, and this is called peripheral circulation. So there are very, very tiny blood vessels called capillaries that reach the blood to the nerve cell, that carry the oxygen to the nerve cell, and when the blood supply goes down, then the oxygen supply also goes down to the nerve cell, and this causes hypoxia, it causes neuropathy, and the symptom that the patient experiences is pain in the hands and in the feet, especially the sensation of pins and needles. It is extremely painful. So one common drug that is prescribed by the doctor for diabetic neuropathy is called gabapentin. So gabapentin is basically a painkiller. So it works by blocking the neurotransmitters from reaching the pain receptors. So the way that the patient experiences pain, or the way we experience pain in our body, is that, see, this is the axon of one nerve cell, and this is the dendrites of one nerve cell, and the dendrites contain, these are pain receptors, and the neurotransmitters, basically they send a pain signal. So these are neurotransmitters, these are transmitters that signal the pain. So when the neurotransmitters come from this cell nerve and settle down on the pain receptors, then you are able to experience the pain. But what gabapentin does is that it will block this pain receptors. So it will temporarily block this pain receptors, and by blocking these neurotransmitters, by blocking the pain receptors, it is also blocking the neurotransmitter from attaching itself to the pain receptor. And so therefore by blocking these neurotransmitters, gabapentin tries to numb the perception of pain. So the patient is not able to feel the pain. But one of the problems with gabapentin is that a comprehensive study by the Cochrane review, it has shown two things. One is that gabapentin, this is what we are talking about over here. We are saying that gabapentin, according to Cochrane, gabapentin works only for a short time. So it is a temporary pain relief. Secondly, this study also says that gabapentin does not work for everyone. It does not give pain relief for everyone. It is only a subset of the patients for which gabapentin provides relief. So Cochrane collaboration, understand, is one of the very respected publishing houses which assesses several studies. Whatever is the evidence for gabapentin, it does a thorough study of all the studies, and it gives a verdict. The verdict given by Cochrane in this case is that gabapentin does not work for everyone, and it works only for a short time. So the best way to treat neuropathy, if gabapentin is useless, the best way to treat neuropathy is to go to the root cause of the problem. And the root cause of the problem is the reduction in the prostaglandin E1 levels or PGE1 levels. So the root of the problem is a reduction in the PGE1 levels. This happens because in diabetics there is a metabolic block in the GLA metabolic pathway. So the GLA metabolic pathway is the metabolic pathway used to produce PGE1, but in diabetics this metabolic pathway there is a block. So as you can see, the nerve cells are here, and there are capillaries, small capillaries through which the blood flows, especially the RBCs. But the RBCs are very, very large. They are very large, so it is very difficult for the RBC to squeeze through this small capillary. So the RBCs have an ability called deformability. Another name for RBC is erythrocyte, and so there is a quality of these RBC called erythrocyte deformability, where they are able to deform and change the shape, and they are able to squeeze through these capillaries and reach the nerve cells, thereby providing them oxygen. So the nerve cells are happy. PGE1 basically gives the erythrocyte the ability to deform. So PGE1 promotes erythrocyte deformability so that the nerve cell gets adequate blood supply and oxygen. PGE1 is also improves the vasodilation. So for vasodilation of the capillaries, so that more blood can reach the nerve cells. See, since capillaries and micro blood vessels do not have an endothelium, they cannot use a vasodilator and make nitric oxide. The vasodilator in such case, so the nitric oxide cannot function as a vasodilator. So the vasodilator for such small blood vessels and capillaries is actually PGE1. So this is why the best treatment for diabetic neuropathy and to restore the blood supply in these capillaries is to restore the PGE1 levels using the GLA metabolic pathway. So this is the GLA metabolic pathway. As you know, linoleic acid, we have seen this in the previous folder also. Linoleic acid becomes GLA, GLA becomes DGLA, and DGLA produces PGE1. Now in diabetics, there is a delta 6 denaturase block, and because of this metabolic block, this linoleic acid which we get from our oil that we take from the diet is not converted into GLA. Now if there is a block here, then the entire GLA metabolic pathway does not work and PGE levels become reduced. So with GLA, what we are doing is, because there is a metabolic block over here, we are giving GLA directly through dietary GLA. So dietary GLA gives GLA directly to make DGLA and to restore the production of PGE1. Further, because we are not giving plain GLA, but we are giving ascorbyl GLA, which is GLA plus vitamin C. Because of that, what happens is, this production of PGE2 is not there. So when this metabolic pathway produces both PGE1 and PGE2, but when you give it as ascorbyl GLA, this production of PGE2 is blocked because we don't need PGE2. Therefore, the PGE1 production becomes more. Here there is only less production with regular GLA, but with ascorbyl GLA, PGE1 production is more because there is more ascorbyl GLA going towards the production only of PGE1. Nothing is wasted on PGE2. That is why ascorbyl GLA is much more powerful than plain GLA. So in our compass, we are basically saying that, doctor, there are drugs like gabapentin that provide a temporary relief by relieving pain in diabetic neuropathy. That is what we say here. Drugs like gabapentin provide only temporary pain relief in neuropathy, and that too only to some patients. For a lasting solution, you need MecGLA because MecGLA treats the root cause of neuropathy. So here we are saying that since PGE1 is responsible for neural hypoxia, you need GLA for permanent relief. As you know, doctor, neuropathy in diabetics is caused by a metabolic block in N6 fatty acid metabolism. This block affects the peripheral blood circulation and causes neuronal hypoxia and neuropathy. How can this metabolic block be corrected with just painkillers? Therefore, please prescribe MecGLA, doctor, daily for at least 3 months.